Hello, I bring you the block of the month for AORA, and my block is USG Guided Femoral Nerve Block. Myself, Dr. Gaurav Agrawal, Senior Consultant from Care Hospital, Bhubaneswar, Odisha, India, and we have a 1 year AORA fellowship under Professor Dr. Ritesh Roy. I declare no conflict of interest or financial support, and consents were taken. The femoral nerve is formed by the dorsal division of the anterior primary rami of the spinal nerves from L234, which also form the lumbar plexus, and the femoral nerve is the largest branch of the lumbar plexus. The femoral nerve is the chief component of the anterior compartment of the thigh. The femoral nerve is sandwiched between the psoas and the iliacus muscle, traverses behind the psoas and gives higher articular branches to the hip joint in the abdomen. It also supplies to the iliacus and pectineus in the abdomen and then passes behind the inguinal ligament into the femoral triangle or the femoral compartment. About 4 centimeters below the inguinal ligament, it divides into anterior and posterior division, and anterior division supplies to the sartorius and the two cutaneous branches. The posterior division gives branch to the rectus femoris, which also supplies to the hip joint, whereas the other branches are supplied to the quadriceps. The nerve to vastus medialis gives a medial retinacular branch which supplies the knee joint or the knee joint capsule on the medial part. Then it terminates as a saphenous nerve and gives infrapatellar branch, and in the leg and the foot gives cutaneous branches. The whole of femur, medial portion of the tibia and the hip joint are supplied by branches from the femoral nerve, whereas the muscles quadriceps, sartorius, rectus femoris, pectineus and iliacus are supplied by the femoral nerve. The dermatomes, the anterior part of the thigh and medial portion of the leg, ankle and foot are supplied by the femoral nerve. Any surgery involving femur, knee, patella and quadriceps are clinical indications for femoral nerve block. Postoperative analgesia for hip surgery, knee surgery, the femoral nerve can be given. And for knee surgery, the femoral nerve is combined with the IPAC or LIA. For below knee surgeries, it can be combined with the popliteal sciatic block. For hip fractures on arrival block, femoral does wonders and aids in good analgesia. For block preparation, we need to obtain a consent, go through the checklist before the block, confirm your site sterility protocols. We will be using a linear high frequency transducer probe with a 100 mm needle for in-plane needling. The drugs for surgical anesthesia, we need 0.5% bupivacaine or levobupivacaine. For analgesia, 0.25% of bupivacaine or 0.2% of ropivacaine with adjuvants to prolong the block in a volume of 15 to 20 ml. The patient lies supine, leg neutral or externally rotated. Operator stands on the ipsilateral side and the machine on the contralateral side in front of you. Start with the scanning phase. The transducer is placed parallel to the femoral crease to identify the femoral vessels. Here we can see the branched femoral arteries into profunda and superficial femoral artery and the vein. From here we go cephalad, move our probe cephalad towards the inguinal ligament, closer to the inguinal ligament to identify the common femoral artery and then the various structures. So first we will identify the femoral artery, then the iliopsoas muscle lying lateral to it, then the fascia lata and iliaca. So fascia lata goes above the artery, whereas the fascia iliaca is close to the iliopsoas muscle below the artery. Then we can identify the femoral nerve, which is sandwiched between the fascia iliaca and the iliopsoas muscle. The fascia femoral nerve lies below the fascia iliaca on the superomedial quadrant of the iliopsoas muscle. This is the reference for the ultrasonographic identification of the femoral nerve. Femoral nerve can be anisotropic, so we need a little bit of tilting to cephalad or caudad to increase the echogenicity of the femoral nerve and identify the various structures. In-plane needling is done from the ipsilateral side only, and this is a short video of the USG guided femoral nerve. We start the scan from the femoral crease, identify the branched artery, profunda and superficial femoral artery along with the femoral vein. From here, we'll slowly slide the probe cephalad to closer to the inguinal ligament and identify the common femoral artery. We'll move the probe a little lateral to identify the common femoral artery, the iliacus muscle, the two fascia, and the femoral nerve sandwich between fascia iliaca and the iliopsoas muscle. The needle enters in plane towards the femoral nerve with the tip under vision all the time. Enter the fascia iliaca and aim to miss the nerve. Enter the lateral margin or lateral edge of this compartment where the compound femoral nerve lies, and with negative aspirations in small aliquots of 2 to 3 ml, we'll inject 15 to 20 ml of drug to wash the femoral nerve in whole. So this is how the small aliquots of injection, and you can see the femoral nerve nicely washed. For out-of-plane technique, we don't usually do a out-of-plane technique for a femoral nerve block, but if you aim to do a out-of-plane technique, you have to target the same lateral margin or lateral edge of this compartment which contains the compound femoral nerve. For assessment of the femoral nerve block, we ask for the spunt movement of the leg, inability to perform the task signals a successful femoral nerve block, where the patient is asked to raise the leg from extension, extend the knee or against resistance. If it is splinted, we request the patient to contract the quadriceps muscle. Or the first sign of onset of block is the loss of sensation in saphenous nerve territory, which can be assessed with a cold touch technique. To summarize again, correct angle of the probe placement in relation to femoral artery is very important to identify the various structures and the femoral nerve. If we identify the divided femoral artery into profunda and superficial femoral artery, we need to move our probe cephalad to identify the common femoral artery and then the different structures. And then after you identify the two fascia and the iliacus muscle, you can easily identify the femoral nerve. Again, fascia iliaca is the key structure to recognize the femoral nerve. The femoral nerve always lies below the fascia iliaca in the supromedial quadrant of the iliopsoas muscle. It lies always below the fascia iliaca. So you need to identify the fascia iliaca to identify the femoral nerve. And the drug should be deposited on the lateral edge below the fascia iliaca and appreciate the pop of the fascia iliaca and see your drug spread in real time using an ultrasound. Thank you. That was all from my side. Thank you, AORA, for the opportunity. Thank you.